as you guys all know, dealing with the causes of drug shortage are much more important than dealing with the symptoms, and stopping them from happening in the first place would be great, wouldn't it? So what Cassidy and Hatch are doing is very important. Thanks, Joe. I'm Matt Brow. I lead the Government Relations, Public Policy, and Reimbursement Strategy function for McKesson Specialty Heath, which is a division of McKesson Corporation, and also for the U.S. Oncology Network, which is a group of about 1,000 physicians around the country who are supported from a business and administrative perspective by McKesson Specialty Heath since the acquisition of U.S. Oncology, the corporation, about 20 months ago by McKesson Corporation. So I've been asked to give a very simple task here today, which is to boil about 2,000 pages of legislation down into about 20 minutes, and also give you an opportunity to ask questions about it and talk about it if you'd like to. So I'm going to try to do that. But before I do that, I want to start with some context around where the marketplace for health insurance coverage stood and stands before the coverage expansions go into effect as it relates to the Affordable Care Act. The obvious thing that jumps out at most people here is, wow, employer-based insurance is a big deal, and wow, the government is a big deal. A lot of people in this country have health insurance from their employer, from the federal government in the form of Medicare, Medicaid, CHIP, and so on. There is a very small, a reasonably small, and largely dysfunctional individual insurance market. The people that really need insurance in that market find it difficult to get or impossible to afford. And then you have a rather large population of uninsured in this country. It's important to note that of this 45 million, also somewhere around 15 or so, or 20 million are not citizens of this country. Some may be legal workers in this country and some may not, but at least 10 million or so of this 45 million population is likely to be an undocumented worker or a resident here. So what does the Affordable Care Act do? In my view, there are two core purposes of the Affordable Care Act. Two core things that this massive multi-trillion-dollar bill attempts to do. The first is to take a chunk out of that 45 million uninsured population. The Affordable Care Act does this in two ways. One, by creating a new set of subsidies for people to buy private health insurance through what will be created in exchanges at state level or federal level. Those subsidies can go up to 400% of the federal poverty level, which is almost $100,000 for a family of four in a lot of places. So it's a pretty broad set of subsidies. The second piece has to do, and it's about half and half, by the way. Some estimates are about 30 million people that would be insured, some 32 million. Some are going down now for reasons I'll talk about shortly on the Medicaid side. But the other piece is to expand Medicaid for all people under 133% of the federal poverty level. Some states only allow women with children to get Medicaid now, or families don't allow single workers and folks like that to do that. Other states have requirements that it be under 100% of the federal poverty level and so on. So these are the two ways. All of this is paid for by new taxes and cuts to existing spending programs. So there are taxes on individuals, there are taxes on health plans, taxes on pharmaceutical companies, taxes on medical device companies, and then you have a whole set of cuts to things like Medicare, which a little bit important to a lot of people in the room here. The discussion over the last several weeks in the election, since the pick of Ryan by Romney as a running mate around the Medicare program, has brought into some relief the concept that the ACA actually cuts hundreds of billions of dollars out of Medicare. That is true. It cuts a lot of money out of Medicare. It doesn't all impact us directly, but it will impact somebody eventually. That money is taken then, just like the taxes, and pooled together to pay for all of this expansion of coverage. So that's number one purpose of the ACA, is to raise a whole bunch of money, probably about $2 trillion fairly over a 10-year period when the whole thing's in place, and spend it on covering 30 million people, give or take. The second big thing that the ACA does is create a new federalized regulatory regime for health insurance in this country. Until the ACA, most of the decisions associated with health insurance coverage and the regulation of health insurance coverage have been made at the state level, with state bureaus of insurance and insurance commissioners and so on. What the ACA does is regulate almost like a regulated utility like a nuclear power plant or a phone company, everything about the way that the insurance company goes to market and operates. That includes how much they can charge, who they can charge what to, how much profit they're allowed to make or not make, that they have to send rebates back to beneficiaries if they make too much profit, what kinds of coverage they must offer in a variety of different buckets, how much out-of-pocket requirements can be. There are a wide variety in very minute detail on the things that are required of health insurance companies under this new regulatory regime. And at the same time, the ACA in this second bucket regulates the activities of individuals and employers. So one of the things that the ACA does, there's been a fair amount of discussion around this over the last year and a half or 2 years or even 6 months, is say to every individual in this country, you must have a qualified health insurance policy, either through your employer or through something you purchased on the exchange, or that you got from Medicare, Medicaid, S-chip, so on. Or you have to pay us, the government, a penalty for not having that. That's typically known as the individual mandate. I think it could be argued that it's not a mandate, but a trade-off. You do this and you pay, and you don't do this and you don't pay. But in any case, it's typically been called that. Similarly, there's an employer mandate, which also is arguably not a mandate, but which says if you don't provide health insurance at a level that we set a minimum standard on to your employers, if you're over 50 employees, you have to pay a penalty to the federal government. So all of these things then come together to create what is supposed to be a working healthcare system where everybody pitches in and the health insurance companies get a reasonable profit but not too much profit. So that was all thrown into question over the summer when we were all wringing our hands about and saying, what will the Supreme Court do? Will they strike down the whole law? Will they strike down the mandate and leave the rest of the law standing so that the system doesn't work? I think most people did not guess the outcome of this one, at least in the detail. But the interesting thing here really is that there was some bipartisanship on this issue. But if you recall Mr. Verrilli's statements before the court, he argued on the first day that the mandate is not a tax, and on the second day that the mandate is a tax. And in the end, his second day argument won. As it turns out, it is a tax, according to the Supreme Court, but not according to the administration from a political perspective, obviously. And the most interesting thing, really, is you have a Chief Justice who initially voted to strike down the whole law on the first day of voting, which typically leads to a set of writings of opinion and then the signing off of those opinions with the same vote, typically, is what it started with. In this case, he changed his mind halfway through and actually switched to the side that upheld the majority or the most controversial portions of the ACA. Now, one interesting thing to think about is how big the bill was, how much was in it. And you guys all probably remember that when the House passed the bill, they hadn't read it because it hadn't been published yet, because it's several thousand pages. And what the speaker said at the time was, guys, you know what, we'll have to pass the bill and then we can read it and figure out what's inside it. And so that's what they did. And in many cases, they got some things wrong. The biggest thing, when it turns out, there are two big questions in front of the Supreme Court. The one was, is the individual mandate this compulsion of commerce instead of regulation of commerce? Is that constitutional? That was question number one. And then question number two was, is the way that the ACA attempts to get states to expand their Medicaid programs unconstitutionally coercive? So is there too much money at stake that states almost can't say no, and so the federal government is kind of bullying states into making decisions to expand their Medicaid roles and Medicaid programs? On the first case, in the first instance on the mandate, what the court said was, this is not constitutional under the Commerce Clause, but it is a tax. And if it's a tax, it's constitutional under the federal government's wide-ranging taxing authority. What essentially this means, though, is that if there's any behavior that the government wants you to do or not to do, unless some further Supreme Court decision is made in this area, the federal government can always tax you if they don't like your behavior, can always not tax you if they like your behavior. And that's an interesting expansion of the federal government's powers, at least in the way that I've thought about them over time. The second question is potentially more far-reaching even than that, which that sounded pretty big to me when I thought about it. But the second question is, can the federal government coerce states with money? And if you think about a lot of the interesting social policy decisions that have been made over the last 20 or 30 years in this country, a lot of them are required to be made at the state level due to the Constitution. And a lot of them have been made at the coercion of the federal government relating to funds, particularly highway funds. So you wouldn't have ever had a national speed limit unless the federal government had said, I'm pulling back your highway funds if you don't go to 55. You wouldn't have had a 21 drinking age if the federal government wouldn't have said, I'm going to pull back your highway funds unless you go to 55. All these things are potentially unconstitutional in light of the Supreme Court's decision relating to the Medicaid expansion, and in fact could potentially change the way that the federal government and the state governments interact with each other inside and outside of healthcare over the next forever, essentially. So with all that said, from our perspective, the ACA in and of itself, not just discounting the underlying environment and the environment that comes after that, the ACA in and of itself probably should be a good thing for oncologists and for cancer patients in this country. I say that because patients will be more likely to be insured. If they're diagnosed with cancer, they're likely to have a rather expensive set of treatments that are associated with trying to help them survive that cancer and thrive after it. Oftentimes, or at least in our estimates and data, the average is $100,000 or more for a medical oncology patient, and that's kind of a big deal. So if you don't have insurance and you have $100,000 staring in your face, it's a little bit more difficult to try to get to where you want to be. Next, it'll be easier to get insurance in the first place. So even if you don't get a subsidy, it's going to be harder to exclude you from insurance just because you were previously diagnosed with cancer. Thirdly, if you have, again, a very expensive course of care over a year or over time, for some patients today and over the last 10 years, it's been possible to actually run out of health insurance at a certain level, and that won't be possible anymore. And a big deal from our perspective also is that the routine costs of treatment associated with participation in a cancer clinical trial will be covered by all plans after this goes into effect in 2014. And then finally, there are limits on out-of-pocket. So all those things should kind of lead together to a better environment for patients and the people that take care of them, particularly in expensive conditions like cancer. So what's happening next? There are a couple of things left to go. A little bit more meat on this bone, and I think the core thing is a lot of the big stuff, the big spending happens in 2014. Some of the regulatory stuff is already happening. There's a little bit of medical loss ratio stuff bouncing around out there. Maybe some plans will have to send rebates to their beneficiaries. But the core of that number one and the core of that number two, of the two big buckets we talked about at the beginning, the coverage expansion and the regulatory regime, the biggest chunk of that all happens on January 1 of 2014, which leaves a fair amount of opportunity for mischief if there are folks that want to roll that back. And obviously there are some that would like to put it in reverse and roll it back. They've taken 32 votes to repeal it in the House over the last 18 months, give or take. And without any question, there will be more votes to repeal it after the election, regardless of how the election goes. The only question will be if it can actually be enacted, the repeal of the various pieces. My personal point of view on this is that it is entirely possible for the first bucket of the ACA to be repealed in whole or in large part, the spending piece. And the reason I say that is because it only would require, under budget reconciliation rules in the Senate, 51 votes to repeal all of that stuff because it would reduce the deficit by cutting out spending. The regulatory piece, almost in its entirety, could not be done through the budget reconciliation process and would require 60 votes in the Senate, and as a result, it would be very difficult to repeal that part. So what you could end up with in a very interesting way is a guaranteed issue requirement, a set of utility-like regulations around health insurance plans, and no new covered individuals. So it'll be fun to see how that works. But let's just assume for the moment that it doesn't get repealed. And that everything is supposed to happen and get ready for 2014. Now, I don't know if anybody ever signs up for their own health benefits. I imagine most of you probably do. You have to do it probably right around now for next year, at least I do. I'm supposed to sign up in a couple weeks, which means that for 2014, you have to be able to sign up for your health plan by at least now if you want to be in a health plan, which means that there has to be a health plan before this time next year, which means that there have to be some rules associated with what the health plan can look like through the exchange. There has to be an exchange that exists or works, and none of those things are done in most places right now. A lot of states were just saying, let's see what the Supreme Court does, and then after that, a lot of states have been saying, well, we don't want to do it anyway, even though the Supreme Court said that it's all right, and this is likely to go forward. So you have a massive undertaking that I would argue the federal government is not particularly well suited to. Now, if they had, let's say, given this job, instead of giving it to CMS, maybe to the federal employee health benefit plan folks who do this, create cafeteria plans and put them together for millions of people to choose amongst and certify plans to go inside of it, that would be perhaps a different story, but that's not how it is. So I think it's going to be a challenge for the government to get to where it needs to be over the next year and a couple months to get ready if this actually goes off as planned in 2014. The other big thing is now, because of the Supreme Court decision, states have an opportunity to say, I'm going to expand my Medicaid program, or I'm not going to expand my Medicaid program. Many states have already said, I'm not going to do it. Some of those states would have been facing billions and billions of dollars in liabilities that they wouldn't have otherwise prepared for over any period of time. Texas, for example, has one of the lowest rates of Medicaid coverage in this country, and if required to go up to 133% of the federal poverty level under the ACA, which they would have been, they would really have had a very significant increase. Now, Texas has already said they won't do it. There are other states that have already said they're not going to do the expansion too, and as a result, I think we're going to see far fewer than 15 million or 16 million new Medicaid beneficiaries. One of the interesting things would be, though, if one could find a way to move those patients into the exchanges that are created under the ACA as well and allow them to receive federal subsidy to buy private insurance coverage, just like the people between 133% and 400% of the federal poverty level, that could actually be a win for a lot of those patients. And certainly a win for the state that doesn't have to pay for the Medicaid beneficiary. But there have been some recent studies, some of you have probably seen, indicating that it's not a whole lot better from an outcomes perspective for a patient to be insured by Medicaid than it is for them to be uninsured. And there are probably some reasons for that. But a lot of physicians and providers and other folks are not participating in Medicaid programs around the country, and that's some of it. If you could get better coverage that's not Medicaid, one would probably want to do that. And so maybe there's some upside for folks in this. It's also possible that there will just be a larger population that remains uninsured than was previously thought to be the case. So most governors, and particularly Republican governors, and I love these guys, but you know, we have personal responsibility. That's a core aspect of the things that we believe in. But when you take a look at who's actually made a health insurance exchange at the state level, there are a great number of Republican states that have decided not to do it, either because the governor did or because the state legislature said we won't do it. And as a result, the federal government will be running exchanges to the extent that they exist in many of those states, which is an intriguing thing. Essentially, it's saying, I don't like this, and I like it so little that I'm going to let you do whatever you want with it.